Ted Frech, thank you very much indeed for talking to me this afternoon. Understanding your conference presentation, you're going to be talking about President Obama's health reforms and the Affordable Care Act, and in particular about the ACOs, the Accountable Care Organisations. Could you tell us a little bit about those for the uninitiated here, please?
Sure. ACOs, or Affordable Care Organizations, they're really a proposal at this point. None of them exist. They're really kind of an abstract idea. There's a vision for them. There's a lot of regulations have already been proposed for them, including some antitrust regulations and then also regulations on just how they can be formed and so on. They're meant to be, I would say, roughly speaking, a very soft kind of a managed care system. That would be the one sentence way to describe it, I think.
Okay. And how does it differ from sort of more traditional forms of managed care then?
Okay, it's far looser. And it's actually meant for the fee-for-service part of Medicare. So people get assigned, they don't have to actually join the beneficiaries. They get assigned according to their historic primary care use. And if their historic use involves someone who later goes into an ACO, they are assigned to that ACO.
So that patients don't have choice up front of which ACO they join, is that right?
Correct. And in a sense, they don't join, they just are attributed, in fact, after the fact.
Okay. And is there any evidence yet that these things are able to contain cost and improve quality and access?
Well, I would certainly not direct evidence because they haven't existed yet. There was an experiment a couple of years ago, well, it's still continuing, physician group practice experiment that the Medicare did, where they had organizations that were really the prototype for the plan, sort of. There's another sense of prototype too, which I'll talk about in a minute. But they had people attributed to them in a kind of similar way. And basically, I think the short answer is it didn't make that much difference. There were 10 of these plans. Most of them did not attain any savings, so they didn't get any shared savings. One of them got a fair amount, and two or three of them got very small amounts. So I would say it wasn't a huge difference. On the other hand, nothing terrible happened, and it was a short-term, maybe 3-year, maybe in its 4th year now, experiment.
You mentioned antitrust earlier on. Could you explain what the issues are there?
Sure. Antitrust, which would be called competition policy here, is making sure there's competition. It's very active in healthcare in the U.S. And there's a concern that these accountable care organizations, by allowing collaboration of competitors, could reduce competition, in effect form cartels of physicians and/or hospitals. And so there's already been promulgated some guidelines about how that will be prevented by U.S. antitrust or competition law. And the guidelines are from the Federal Trade Commission and the Department of Justice jointly. And you can see them, they're in the Federal Register.
And what kind of things do they cover, those guidelines?
They cover particularly market share, that the ACOs will not be investigated if they have 30% or less of the market. And the way the market's defined is important, but sort of somewhat complicated. It's the service area of the proposed ACO, where it gets 75% of its customers geographically, and then medical care is split into 25, I forgot exactly the term, but they're like diagnostic-related groups, except they're much smaller. So it's to 25 instead of hundreds. And
presumably ACOs may help to improve clinical integration if they're promoting collaboration between providers. Is that true?
Yes, they're designed to improve integration, and also I would say to give some incentives for a little bit of non-price rationing or demand management, you might call it, but not in a managed care setting. It's basically a fee-for-service setting. So the ACO plan doesn't change payment. There are separate reforms in the pipeline that may offer or ultimately require different payment systems, but that's separate from the ACO system.
So from a patient's perspective, how am I going to notice that my care is more integrated, if you like, by being part of an ACO?
I think you could easily not notice, except that the physicians are going to be required to have signs in their offices and so on, so you will be told. But you could easily not know the difference. The incentives are fairly small, so the differences might be fairly small.
So if the patient's not going to notice any difference, how How is it ever going to achieve its stated aim?
Well, I think that's kind of an open question. The idea is that there'll be more information flow among the providers who have signed on to this, and that they will therefore integrate their behavior better, and they will have an incentive as a group. If they reduce costs below what costs would have been, they will get some of the savings. It's called the shared savings. Fortunately or unfortunately, it's fairly limited. It's a fairly small incentive. So it may not really work very well.
And I understand that there are now some prototype ACOs beginning to emerge. Could you bring us up to speed what the latest state of play is?
Well, I wouldn't say it's that late. There are these 10 that were in that experiment. The Marshfield Clinic was the one that had the biggest savings in Wisconsin. They're kind of prototypes, especially for this attribution way people get, beneficiaries get included in an ACO. I'd say a closer prototype in terms of how they'll actually likely work are independent practice associations in the US and large multi-specialty groups. Now, some of those 10 in the experiments were large multi-specialty groups, so there's some overlap in these two. But those IPAs and large multi-specialty groups have been basically successful in the US. They also have been thought to create extra market power and cause competition problems, especially in California.